Good day, everyone. I'm Dr. Choi Yek Ki, pediatric intensivist from Sarawak General Hospital. Today, I'm going to share with you point of care ultrasound lung assessment for extubation readiness. As an introduction, atelectasis is one of the important post-operative pulmonary complications. It can increase the post-operative incident rates, mortality rates, and also use up a lot of medical resources. With the advancement of laparoscopic surgery, and then the incident of atelectasis become more. Lung recruitment maneuver can successfully reduce the post-operative atelectasis in children and adults, but the most effective method and recruitment pressure are still unclear because the key reason is that this lung recruitment maneuver is not monitored in real time. And with excessive lung expansion can lead to lung injury. Hence, today we're going to discuss point-of-care ultrasound in lung recruitment, which is easy to use, portable, non-invasive. You can see the changes by yourself and repeatable and is radiation free. This is the outline of the talk. We talk about a little bit of probe and the basic POCUS lung assessment for extubation readiness test, which is the three important feature that we're looking at, which is lung ultrasound score, diaphragm excursion, and diaphragm thickening fraction. First, these are the common probe that you are having in ultrasound: the linear probe, phase array probe, and curvilinear probe. Each probe has its own function, as we had alluded in the earlier talk in the morning. So what our concentration now, the probe that you're going to use is the linear probe and the curvilinear probe. One is see superficially, the other one is see deeper structure. So now let's talk about these three important parameter or the scanning technique that we want to see: the lung ultrasound score, diaphragm excursion, and diaphragm thickening fraction. So what are they actually? So when you talk about lung ultrasound score, we are looking at the lung expansion, the degree of changes of the lung parenchyma. You can tell through the ultrasound. Diaphragm excursion is looking at diaphragm movement, as you can see this hand movement here. We're going to see the diaphragm movement and diaphragm thickening fraction. Basically, we're looking at the muscle thickening of the diaphragm. So in lung recruitment, basically, we want to see the lung expand. Usually after giving general anesthesia, part of the lung, especially posterior aspect, going to collapse and atelectatic. So before extubation, we would like to have the lung fully well expanded. So this is a lung ultrasound changes that can appear in the different stages of the lung in terms of recruitment. So when you have well aerated lung at this end, this is a lung ultrasound finding as we had discussed earlier. So when the lung is partially collapsed, some atelectasis area, you can see there's some B line. When there's more area of collapse, you can see confluence B line. And the significant patch of collapse, then you can see subpleural consolidations, okay, and more consolidation until lastly the lung all consolidated up. Right. So in terms of lung ultrasound score, basically we are looking at these important 4 changes during the examination. So each changes are given a number or a mark or a value. So like well expanded lung, we're going to give the score of 0. Some B line, you're going to get a score of 1. More B line, you're going to get the score of 2. And subsequently, if you can see consolidation here, you can see you're going to give a score of 3. Unfortunately, the current literature, there's a lot of definitions, so it's rather confusing. Beside that, there are also different area or zone of scanning. Okay, some literature mentioned they are using a 6 lung zone scanning, which is especially for smaller children. Some literature address of 8 lung scanning, 8 lung zone scoring, and some 12 lung zone scoring. So each lung zone score will be given a number of 0 to 3, as we discussed earlier. Hence, the score range for the next 6 lung zone will be 0 to 18, 8 lung zone will be 0 to 24, 12 lung zone is 0 to 36. So these are some of the recommendations, okay, for the lung zones and also their score, right? So for neonate age groups, because they're using 6 lung zone, if you have a total lung ultrasound scoring for all the area which is less than 5, the risk of successful the risk of failed extubation is much more lesser. If it's in the infant group, total age group 6 to 8 zone, the value total lung value should be less than 8. And if those that 12 lung zone, older child should be less than 12 for a successful extubation. So the pitfall is that it is just a suggestive scoring number. And there's unfortunately the multiple study, but different scoring zone and value are given. Okay, so this is basically based on bedsides scoring, and also based on what the area, how many area that you scan. So and it is there's the evidence for that. So this is a nice meta-analysis for effect of lung ultrasound guided recruitment. Yeah, if you could see this table, right, and predominantly of the study have been done in children with the lung recruitment strategy, right. The risk of successful extubation is rather much better and higher. So following that, the second one is the diaphragm excursion. So when you look at the diaphragm excursion, what we're trying to see is that the movement of the diaphragm. Okay, this movement of the diaphragm, okay, can be seen by using ultrasound in these three areas of scanning. One is perihepatic, okay, which is you're going to see the liver and the kidney, and looking at the right diaphragm. Okay, and then left perisplenic. Okay, this is the spleen, this is the kidney, and then this is the left diaphragm, and also substernum transverse view that you can see simultaneously both diaphragm at the posterior aspect. So this is the diaphragm, and then we put a M mode across, and we're going to see the movement of the diaphragm by using the M mode. So this is the area of movement. So this is the place that you put the probe, okay, and then when you put the M mode across, studying it, and you measure the distance from the baseline to the elevation. For instance, these patients have a diaphragm excursion of 1.53 centimeter. Similarly, on the left side, the probe placed on the left side, you're going to see the spleen, the movement of diaphragm. This is a movement, and you do the measurement is 1 centimeter. So for the subcostal view also, you can see both sides simultaneously, right? The diaphragm movement. These are the nomogram published from the Malaysians by the Malaysian radiologists. Yeah. And looking at the nomogram of the diaphragm excursions, this is particularly on the right side of the patients, right? This is a 50th centile. As you could see, the excursion actually varies according to the patient weight and also age, right? So at the birth, okay, it can be about 3 millimeter, right? This is a diaphragm excursion 3 millimeter, to about nearly a teenage age group. It can be up to about 2.3 centimeter or 23 millimeter. So unfortunately, we do not have, because the range are quite varies. Okay, as compared to adult, for pediatric, we are quite difficult to give a value that can assist us to see whether the diaphragm excursion is within the limit or not. So the best way is to just refer to the nomogram, and then or even the eyeballing itself sometimes can tell us whether the diaphragm is moving well or not. Besides looking at the numbers, the other important aspect is that looking at the movement itself. Okay, so if you could see in this earlier scan, so you can see that these diaphragm are both moving quite simultaneously. Yeah, but this diaphragm actually, you could see the left diaphragm are moving well, but the right diaphragm is not moving well. So this tell you that these patients have right diaphragm paralysis. Bear in mind, if the patient is on the endotracheal tube and is still on the ventilator, we must disconnect the patient from ventilator before doing this assessment, because positive pressure will make the assessment a bit difficult, because the movement can be due to the positive pressure ventilation. This is another example of the poor diaphragm movement. So this is a normal diaphragm movement, but if you could see here, the diaphragm movement is not very great. Okay, one had to remember, the diaphragm movement is not great. It's not only because of the paralysis. Sometimes the consolidation or the changes of the pathology of the right lung can affect the diaphragm movement as well. For this patient, the patient have a pneumonia over the right side of the lung that causing the reduced movement of the right diaphragm. Similarly, in this example, right, this diaphragm did not move very well, okay, because there is a significant lung changes here that cause the patient to not have good respiration effort. Yeah. The third entity is diaphragm thickening fraction. So what are we measuring is basically the changes of the thickness of the diaphragm. Okay, so this is the skin, This is a fat. Okay, then this is the intercostal muscle. This is the area of the diaphragm. Okay, followed by this is the liver, and here is the lung that will come in intermittently. So we put a M mode across it, and then look detecting the movement, the thickening of the diaphragm in this method. So with the M mode study, then you can measure the difference between the contraction and relaxation. So this is what we are actually measuring. We are actually measuring the contraction of the diaphragm. Like for example, like what you show in this picture, measure the contraction and relaxation. So put the M mode across. This is the time when the dilatation is the time when there is contraction and then relaxation. Okay. Then you're going to measure the difference between the contraction and the relaxation. And we find the difference between the contraction and relaxation, and we divide it during the relaxation. So this is what I call diaphragm thickening fraction in terms of the percentage. So difference over the relaxation, this one, the DTF is 38%. This study basically published in 2024, although it's looking at the adult and also in the patient with critically in ICU. Okay, it sum out the patients from altogether about 26 study. Okay, looking at the review of patient using the diaphragm assessment of the possibility of extubations, right? So the predicted cutoff from this study for the diaphragm excursion is more than 1 or 1 to 1.4 that make the success of the extubation will be higher. And also for the diaphragm thickening fractions, if the patient have more than 30 or 36% of the diaphragm thickening fraction, the chances for the successful extubation will be higher. All in all, we had gone through the probe and then 3 important way of how to use point of care ultrasound in assessing extubation. But one had to always remember, POCUS has a limitation. It's operator dependent, machine dependent, and availability of acoustic window. Yeah. With that, thank you very much for your attention.